And then pass the ball to you, George.
Thank you.
All right.
Okay. And a few housekeeping items before we start. As you probably already noticed, you are all muted as you join the webinar, which means you will not be able to unmute yourselves. During the presentation, you can type your questions and comments in the chat box. The chat box is that speech bubble you see toward the bottom of your screen, right where you see the PowerPoint presentation. We will pause periodically for your questions from the chat box.
Sorry to interrupt, but
Sure.
you're showing your presenter view.
Okay, all right. Let me bear with me 1 second here. Bear with me 1 moment. Sorry for the delay there. As I was saying, you are all muted as you join the webinar, which means you will not be able to unmute yourselves. And during the presentation, you can type your questions and comments in the chat box. The chat box is that speech bubble you see toward the bottom of your screen, right where you see the PowerPoint presentation. We will pause periodically for your questions from the chat box. Just please make sure that those questions are going to all participants so we can keep track of them. If you would like access to the closed captioning, we have two options. You can view the captions in the panel in the lower right corner of your screen, or you can view them in a separate window by using the link that is posted in the chat box. This webinar qualifies for continuing education credit from the Medical Library Association. We will have more information on how you can claim that credit. It's very important after the talk today. Welcome to NNLM Reading Club Presents, a series of online discussions with engaging authors writing on health, health information, and health equity. This is the first talk in our series. I'm George Strawley, and I will be your host today. Assisting me in the presentation will be Michelle Spotts, Darlene Caskey, and Maddie Rosemanzik. The Reading Club and this series are the result of funding from the All of Us research program under the National Institutes of Health. The mission of All of Us is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. All of Us will help researchers understand more about why people get sick or stay healthy. By looking for patterns, researchers may learn more about what affects people's health. All of Us aims to build one of the largest, most diverse data sets of its kind for health research, with 1 million or more volunteers nationwide who will sign up to share their information over time. The program aims to reflect the diversity of America through its participants and is part of the Precision Medicine Initiative. To learn more, visit joinallofus.org/NLM. The NNLM All of Us Community Engagement Network brings America's public libraries into the All of Us partnership. The network will provide awareness of All of Us and improve access to health information through libraries to aid people in making informed decisions about their health. Visit nnlm.gov/allofus for more information. Our guest today, Dr. Robert M. Wachter, is considered the father of the hospitalist field and coined the term in 1996. He serves as professor and chair of the Department of Medicine at the University of California, San Francisco. Dr. Wachter was named the most influential physician executive in the U.S. by Modern Healthcare magazine in 2015. He is the author of 6 books, including The Digital Doctor, Hope, Hype, and Harm at the Dawn of Medicine's Computer Age. He is here today to talk about that book and what has happened in the fields of healthcare and health IT in the 3 years since it was published. Welcome, Dr. Wachter.
Thank you, George. It's a great pleasure to be here, and admired the All of Us program. And it really is a nice example of taking advantage of digital technology to collect data, analyze data, and use it in ways that will improve health and healthcare. So it's a real pleasure to be here. It's also a pleasure to be here because I don't plan on discussing COVID the entire time, whereas for the last 3 or 4 months, it feels like that's all I've been doing, both on Twitter and with a whole lot of media appearances. So we will get into COVID, but I'm going to start by talking a little bit about where we are in our technological journey in healthcare. And George and the others asked me to spend 10 to 15 minutes just talking through some of the key issues. I hope some folks have had a chance to look at the book, but I'll assume not. And then we'll have plenty of time for questions and discussion. So let me start with kind of my motivation to take a year of my life. This is now 4 or 5 years ago, and try to better understand the moment that we were in healthcare as we were shifting really from one way of doing work to another. If you think about it, in a decade ago, fewer than 1 in 10 American hospitals had an electronic health record. Today, fewer than 1 in 10 does not. It's actually probably more like about 5% now do not. And similar numbers would be true if you looked at physicians' offices out in the community. So it is not an overstatement to say that in the last 10 years, we have gone from a business, if you think about healthcare, it's really all about information and how it's collected and shared and analyzed and used in service of health. We've gone from a business whose fundamental way of collecting and disseminating information was writing them down on pieces of paper or Post-it notes and then sharing them through fax machines or people picking up one chart and moving it from one place to another, to a business whose fundamental way of collecting and moving around information is digital. That is a very big deal. And the reason I took a year of my life to write about that was I was struck by how badly it was going. The sort of magical thinking that it was just going to sort of come and we would get digital and it would all be wonderful and seamless was clearly not happening. And I was seeing almost everybody was unhappy about the state of affairs. Physicians were pissed off and nurses were pissed off and people were burning out and everybody hated the electronic health record companies. And so it struck me that this must be an interesting and complicated problem. And if I can understand it better, maybe I can communicate that way in a way that helps people understand it better. So that really was the genesis of me writing a book about it. I took a year and kind of played amateur journalist, part of it on sabbatical in Boston. And I interviewed more than 100 people, everything from frontline docs and nurses, patients in communities of patient disease groups that had formed into digital communities, to leaders of companies like Epic and IBM. I spent a day at Boeing to see how they think about computers in airplanes. It was just infinitely fascinating. And at the end, I felt like I got it. I kind of now understood what the nature of the problem was, why it was so hard, and maybe what would happen to get us out of the predicament and take advantage of the opportunity that digital affords. So let me start off with a brief reading from the book, take a minute or two, and then I will tell you a little bit about what I found and spend a minute or two talking about what I think its implications are for today, and particularly in what's happened in the 3 or 4 months since COVID started. And then again, we'll open it up. So this is a section of the preface where I was trying to kind of describe the big picture of what we got wrong in digital. And it ends with a paragraph that I call the Zoe paragraph because my daughter, after having read a draft, it said, this is pretty good, but you still don't quite say why this matters. And so the last paragraph here is why this matters. Harvard psychiatrist and leadership guru Ron Heifetz has described 2 types of problems, technical and adaptive. Technical problems can be solved with new tools, new practices, and conventional leadership. Baking a cake is a technical problem. Follow the recipe and the result is likely to be fine. Heifetz contrasts technical problems with adaptive problems, ones that require people themselves to change. In adaptive problems, he explains, the people are both the problem and the solution. Leadership, he once said, requires mobilizing and engaging the people around a problem, quote, rather than trying to anesthetize them so that you can go off and solve it on your own. The wiring of healthcare is proven to be the mother of all adaptive problems. Yet we mistakenly treated it as a technical problem. Simply buy the computer system, went the conventional wisdom, take off the shrink wrap, and flip the switch. We were so oblivious to the need for adaptive change that when we were faced with failed installations, mangled workflows, and computer-generated mistakes, we usually misdiagnosed the problem. Sometimes we even blame the victims, both clinicians and patients. Of course, our prescription was wrong. That's what always happens when you start with the wrong diagnosis. And here is the Zoe paragraph. Making this work matters. Talk of interoperability, federal incentives, barcoding, and deep learning can make it seem as if healthcare information technology is about, well, the technology. Of course it is. But from here on out, it is also about the way your baby is delivered, the way your cancer is treated, the way you're diagnosed with lupus or reassured that you aren't having a heart attack, the way when it comes down to whether you will live or die, you decide and tell the medical system that you do or you don't want to be resuscitated. It is also about the way your insurance rates are calculated and the way you figure out whether your doctor is any good and whether you need to see a doctor at all. Starting now and lasting until forever, your health and healthcare will be determined to a remarkable and somewhat disquieting degree by how well the technology works. So that was kind of the epiphany that I had, that part of this was this technical versus adaptive change problem. And clearly we did not get it right. You know, the data show that patient safety with the implementation of electronic health records, patient safety improved a little bit, but costs, which we hoped would go down, went up. That the amount of time that physicians and other clinicians spend documenting has gone up massively, that burnout rates among physicians are sky high. And when you ask them what is the source of their burnout, they talk about their electronic health record and digitization of medicine as either the first or second culprit in why physicians are among the most burned out of healthcare, of any professionals at all. And the grand hopes that maybe we wouldn't be saved by the electronic health records, but by a series of other digital innovators that would come into the digital space and do their story disruption, has mostly not happened. When you look at the companies that have come into healthcare and tried to do their thing, and in the last several years, you see Apple, Google, Microsoft, IBM, all making big plays in digital, saying it's now our time. When you look at the impact those companies have made in digital, it's pretty trivial at this point. And you've even seen some evidence of failure. So I don't know about you, but when I watched the IBM computer beat the Jeopardy champions 6 or 7 years ago, I immediately said, you know, we're all toast. They're not going to need doctors anymore. The computers are smarter than we are. They're going to win. And IBM's foray into Watson for Health has been a massive failure, and I think led them to recognize this is a harder problem than we thought. Then the next version of that I saw was when JP Morgan, Amazon, and Berkshire Hathaway, three of the richest companies in the world, and when you think particularly about Amazon, companies that have truly transformed a number of industries, they decided to band together and form a new company ultimately called Haven, and put Atul Gawande, who was an absolutely brilliant Harvard surgeon and author, you probably read some of his books or read his articles in the New Yorker, in charge of it. So that's going to be a game changer. Unlimited resources, some of the best technology in the world, really smart healthcare leader in charge of it. And Atul just stepped down a couple of months ago, and by most estimates, the Haven has done very little of importance yet. It may still roll some stuff out over time, but it turns out this is harder than it looks. And the digital giants that kind of think that healthcare, that can roll into healthcare the way they rolled into, I know we have librarians on the line, the way they rolled into the book business and displaced Barnes and Noble, and to some extent displaced libraries, or what happened with with travel, or with essentially every industry digital's rolled through, that they'll do the same in healthcare. Turns out to have been a little bit of magical thinking. So let me sort of give you my two main diagnoses. Why is this so hard in healthcare? Why is it taking longer than we thought for the promise of digital to kind of be achieved? And they're both lessons that I think we could have known from other industries, but we tend to focus on healthcare, and don't really understand those lessons quite as well as we should. So the first is a term called the productivity paradox of healthcare. This is a term coined by an MIT engineer and scientist named Eric Brynjolfsson, who's just moved to Stanford. And Brynjolfsson coined the term productivity paradox of IT in 1993. So he clearly wasn't talking about healthcare, because healthcare had very little IT in 93, but he was talking about the experience of industry after industry when technology came in. It was massively hyped. It's going to change everything. It's going to be great. It's going to make everybody more productive. And then, lo and behold, 3, 5, 7 times, sometimes 7 years would go by, and they saw none of the productivity gains that had been hyped and anticipated. You'd go to the factory floor and you see computers everywhere, but the factory wasn't any more productive than it was at the start. And that was true if you went to the Wall Street trading desks, and true in other businesses. And the point that Brynjolfsson and others made was that it often takes a decade between the starting gun, which is basically changing your ways of capturing data and moving around from analog to digital, and the true benefits to be realized. And that's what he called the productivity paradox of IT. The paradox being, we expected it was going to be wonderful and transform us, in a very short period of time. And it often takes 5 to 10 years for that to happen. So when that was analyzed, and particularly in industries that have had more than 10 years and have achieved those benefits in productivity, and you try to figure out what is it that took 10 years, the answer is that basically 2 things had to happen. One is the technology needed to get better, and version 1.0 stinks, and version 2.0 is better, and it's not till you get to version 23.3 C that you really see the promised benefits. But that turned out not be the most important factor in getting past the productivity paradox. The most important factor was that, as Heifetz sort of intimated, the people themselves had to change. You had to change the nature of the way people did work. And that often meant different people or different workflows or different culture. Why did that take 10 years? Because humans stink at this. We're not good at changing. We're not good at sort of even understanding what computers might do for us until we actually are living in a world of computers. And that's why you need some young blood in your organizations, because it's often the young people that ask the questions, why are we doing it this way? And the answer often was, oh, it's because of the way we used to do it, and we just digitize that. The medical record's a perfect example. When you look at an electronic health record and a physician note, when I write a note, it looks like a paper note. It just happens to be on digital form. It's often worse now than it was, because now I have the luxury of being able to import in yesterday's note, which means it may just be fiction. It's basically yesterday's note carried forward. And I can import in by clicking a button all of the X-ray results, all of the lab results. So the note might be 30 pages of just garbage, and no longer can anybody see what's going on. So the computer in some ways has made it worse. The documentation burden is much, much higher, because healthcare organizations are now making doctors and nurses document all sorts of stuff in ways they couldn't have done when it was paper. Which is why the fastest growing profession in American medicine is scribes, is people who come into the room with the doctor and the patient to basically feed the computer so the doctor can actually look the patient in the eye. Again, so all remarkable things, and things that I think are demonstrations of the productivity paradox in healthcare. So I have really come to believe that that's right, and that we really will not see the promised benefits from technology for probably more than 10 years in healthcare, because healthcare is harder to transform. It's more distributed. It's not just a matter of changing how a few companies do their work. If you think about how did the book business change, it really changed because of Amazon. So one company was capable of doing that. Healthcare is too complicated for that. As I tell people all the time, there's always pushback from the incumbents who like their job and like the way things are. And doctors are better lobbyists than taxi cab drivers. So the ability to transform healthcare, when it's going to change the income or the prestige or authority or autonomy of doctors and healthcare administrators, that's a pretty tough thing to do. So there are a lot of reasons why it's going to take probably more than 10 years to go past our productivity paradox. But the message is right, that it's not just putting in computers and magically you've changed everything. You actually have to truly transform the way work is done. And in the beginning, nobody is smart enough or creative enough to do that. They typically put in computers and simply digitize their old ways of doing work. And that's often a generational change. The second lesson that I took was that healthcare IT, and like IT in all industries, has to go through 4 almost discrete stages, and they each take time and effort. The first is the one we've gone through in the last 10 years, which is digitizing the thing. The way we capture data and move it around had to go from paper to digital, or you can't do anything. I was on Google's health advisory board in 2005 or 6 when Google said, we're going to transform healthcare. And you figure they're Google and they're brilliant and they have unlimited money. They'll do it. In about a year and a half after they set up Google Health, they took it down. And I remember Eric Schmidt, the CEO at the time, coming in and talking to our group. And he said, we're getting out of this. This is too hard for us. And I said, whoa, that's pretty hard. And the reason was it wasn't too hard a problem fundamentally, but it was too hard because the data was still being captured on pieces of paper. There was nothing Google could do. That's different now. So you have to start, the sort of foundational is getting the data in digital form, which happens now because of electronic health records, but is clearly insufficient to transform the nature of everything. The second thing you have to do is connect all the digital pieces, and the shorthand for that in healthcare is interoperability. And as you know, that's a work in progress. It is not very far advanced. My Epic system communicates reasonably well with other Epic systems, but communicates not at all with a Cerner system. Communicates highly imperfectly with if you buy a digital glucose monitor, or a digital scale, or a digital anything at home, and have to link that up to your hospital system or your doctor system, that is not plug and play like an iPhone app might be. So we get sort of a plus minus on that. We're moving along, and some federal standards have just put in place to try to accelerate that, but it's been a slow go, and these things are still not evenly or predictably interconnected. And if you think about systems like GPS or the banking system, which are totally interconnected, you see what that looks like. I could stick my B of A card into a Citibank machine, put in my password, and it spits out $200, which is clearly not true in healthcare. The third and the fourth stage is the harder ones, and I think we've just begun to scratch the surface of these. The third stage is you take all that data that's now sloshing around through the system and seamlessly moving around, and you gain insights about predicting things or changing behavior that you couldn't do before. That's real work. It's hard. You need people who can do that. It doesn't just happen automatically because you have a digital system. And I think we've made virtually no progress on that. And the fourth, which is the hardest of all, we've made also almost no progress on, which is you convert those insights into something that you're doing differently. Either the digital system fires and tells a patient to do something differently, or tells a doctor, here's the diagnosis, or here's the right treatment. Or in the world of precision medicine, tells you that this patient would do better with this drug than that drug. There's very little of that actually happens in real life. I'm about to go on clinical service in a couple of days, and I'll be on for 10 days. And there's relatively little meaningful decision support that my computer will give me that really will change the way I take care of a patient or even think about a patient. I'm still glad I have the computer because I can read everybody's handwriting, and a doctor who takes care of the patient in the outpatient world can read my note at the same time I'm reading it, none of which was true in the paper world. But in terms of meaningful decision support that really changes the way we do our work, it's quite limited. And I have a deep knowledge of what this looks like in an industry that strikes me as not being necessarily as important as healthcare, but has gone through these four stages. My older son works in the industry, and they have digitized everything. It's all connected. His job is to glean insights from all the data, and his job is to create actions that change behavior that make it all worthwhile and provide an advantage for his organization. He works for the Atlanta Braves in Major League Baseball, and he does Moneyball, and that's what he does for a living. And I see what it looks like to be at all four of those things. You have the data, it's all connected, you gain insights, and it converts itself in a way that changes the way the people do their work, in a way that creates an advantage. And it just shows me how far behind we are, and partly because we were so late to the digital dance. We're really just in stages 1 and 2. So those are my insights, and it led me to be a little bit less pissed off than I was, because it sort of felt like, okay, we're going to get there. We're just, late bloomers. We were late to the digital dance. We couldn't even begin to start this set of steps until we did step 1, which was digitize the data, and now we're there. So we just spent the last few minutes on kind of what has happened in the last 4 or 5 years since I wrote the book. You now see the re-entry of all of the digital giants and a huge amount of venture capital money being thrown at this. And I don't think, as opposed to last time where Google went away, I don't think they're going away. I think they now that the data are beginning in digital form, they really see whether you're Google or Apple or Microsoft or Salesforce or even IBM coming back. I think they all see the possibility of taking that data and changing the way health and healthcare is delivered and organized in ways that are higher quality, more accessible to patients, disintermediate the healthcare world in ways that could potentially be healthy, where patients can do things for themselves the way you can in the way you manage your finances or your travel and all that. There are ways, and whether it's going to be one of these mega companies that have the advantage of scale and brilliance and trillions of dollars, but the disadvantage of lack of focus, whether it's going to be those companies or companies whose advantage is going to be focused, that they tackle a single specific problem. They figure out a way that a diabetic patient can manage their diabetes better. It's a prototypical company. There is one called Livongo, but there are others out there that, whether it's going to be these sort of multi-purpose digital giants or niche companies, hard to know, probably a little bit of both. Whether it's going to be the electronic health record vendors that already own all the data and make it actually quite difficult to play well with others on purpose, whether they build some of these tools as they're trying to do, like Epic and Cerner, or it's going to be these other tools. Hard to know, probably a little bit of all of them. The interoperability is getting better. It's still not perfect. The federal government has pushed this hard in the last year or two, and I think will make a real difference. This technical thing called an API, which is essentially a little, it's really the way the App Store works. It comes, you need an environment where it becomes almost trivially easy to buy a third-party app, plug it into your electronic health record, and it all just works seamlessly. We don't even think about that when we download an app from the App Store. We need an environment like that in healthcare, and I think we're moving in that direction. Now, what are the forces there? And artificial intelligence has gotten massively better. The science of it has gotten better. The fact that all of us have to store our data in these huge clouds that provides massive amounts of data to facilitate AI. I mean, all of those are very positive trends. The biggest negative trend, I think, is privacy and security, where the same act of taking all your data and not storing it on a server in your basement, because that's unsafe, but storing it on a cloud, whether it's run by Google or Apple or Amazon or Microsoft, the same act of aggregating all of this data in one place makes it vulnerable to hackers. These companies are very good at that, but nevertheless, there's still some vulnerability. Whether whether the data the vulnerability is at the cloud level or in your own system, hard to know. You may have read that some hackers got into UCSF's data system a month ago, basically held us hostage, and we ended up paying them $1 million in order to open up our data. And you may say, like, what are you guys thinking? Don't you know that's just going to encourage people to do it again? That's all very nice and theoretical until you're looking at having to spend $10 or $15 million to get your data out. And that's the problem that we were looking at. And so, the lack of trust, quite appropriate, that people have in digital companies, who's going to really share their data with Google or Apple or you name it, that's getting in the way of all these contact tracing apps that some of the digital companies have built. I'd say that's the big, many of the trends are positive in terms of interoperability moving forward, AI getting better, the entry of a lot of venture capital money, the entry of the big digital companies getting involved in this, all means that we're going to have a more interesting and dynamic digital environment that I think will begin overcoming the productivity paradox. On the other hand, privacy and security issues are a real drag and will hold this back in ways that I think are a little bit unpredictable. Let me say last word about COVID, and then I will stop. COVID is challenging every possible system and enabling levels of innovation that really, that couldn't have happened or would have taken many years to happen to overcome cultural barriers or inertia or regulatory barriers. It's been interesting when I look at what has COVID really enabled in the technology world. The question of, AI, which is sort of the technology that's most hyped and felt like it was ready for prime time, I don't think it's, when I look at the things that have been happening in COVID that are really cool, artificial intelligence doesn't feel like it's a major contributor. On the other hand, an area that is sort of related to artificial intelligence, and there's probably some artificial intelligence going on under the hood, but it really does feel like it has been massively enabled and really exciting, is the use of data to present stories to us in dashboards and data visualization. So, some of you know I've been tweeting about the epidemic, and almost every day I'm on 5 or 6 dashboards that were created for COVID that, in ways that are spectacular and really quite beautiful, take the data and slice it and dice it in ways that then deliver a visualization. And whether you sort of get it from Twitter, or you get it from the New York Times, wherever, you give you visualizations that really are quite elegant and beautiful and help you understand, like, what is going on today in Texas or Florida, or what's happening with the reproductive rate, and what does that really mean? And is the surge in case really just more testing, or is it real? Why are we seeing this lag in deaths behind case? All that kind of stuff. When you ask those questions, the answer is available to you at a click, and not just in the form of like 42 pages of data. Somebody has thoughtfully turned it into a visualization that is really kind of beautiful and meaningful and really changes the way you think. I think that's going to be sticky. I think that we're going to recognize that kind of visualization for healthcare, to see kind of what's happening with my patient, and how's the patient compared to other patients like that patient. And when you look at 1,000 patients like that, when they got treatment A versus treatment B, which ones did they do better with? All that stuff really is, we have the data to do that. We just haven't used it, analyzed it, and presented it in ways, whether it's to physicians or to patients, in ways that are actionable and meaningful and accessible and understandable. I think that's been a real area of progress that has been accelerated under COVID. The PAT answer, which turns out to be both pat and correct, is the main thing that has been accelerated has been telemedicine. That, telemedicine, telemedicine's worked technically for a decade, but its adoption curve has been unbelievably slow. I can tell you at UCSF, where I work, I've been a real proponent of telemedicine for a bunch of years. And through my advocacy and the advocacy of others, just to show you how much influence I have, I'd managed to get us from maybe 0.5% of our visits being telemedicine up to maybe 1.5% in 3 years of haranguing people. COVID did better than I did. It moved us from 1.5% to 70% in 3 months. So, it turns out that when you move from, we want to see you in the clinic, and there's a financial interest of having you come into the clinic, and telemedicine is sort of a pain, and we're not sure if we're going to get reimbursed, and everybody needs a license in every state in order to do it. And so if you're going to do telemedicine across state borders, you're going to need a license in Oregon and a license in Nevada. COVID suspended all of those stupid regulations. It changed the payment model so that we'll pay you the same for a televisit as a regular visit. And it had us saying to our patients, we actually do not want you to come in. And our patients said to us, we do not want to come in because we're worried about getting sick. And all of a sudden, telemedicine went from sort of nice to have to an absolute essential. I don't know that it's going to stay at 70%, but it's never going back to 2%. And I suspect it'll stay at 30 or 40%. So if all it was a visit replacement, meaning that, now I see my doctor maybe every other time, maybe every time in a televisit, 15-minute televisit rather than an in-person visit, that's fine, and I think is a big deal, but not revolutionary. The revolutionary part is now, if the way I'm going to be managed by my healthcare system is largely through a digital connection, I'm not going to go in to see the doctor. You now change the way we think about how I'm going to be monitored from, okay, every 3 months I'm going to go in, the doctor's going to check my blood pressure, my weight, and check my cholesterol and whatever, and make decisions based on that one data point, to now a world where we're all in a mindset of the data point has nothing to do with the visit. It's all about stuff that's digitally connected and collected in my house, maybe every day, maybe in the case of diabetes, 4 times a day. Maybe my digital scale, maybe ultimately my toilet is digitized and it's measuring my urine electrolytes as I pee in the morning. Who knows? But all of that data, as it's collected digitally, now has to sort of get into the healthcare system. And if we do that as a straight shot, I've heard people say how wonderful it's going to be for a primary care doctor to have access to all of that streaming digital data on all of their 1,800 patients every day, and it's just going to come in and it's going to be wonderful. My response to that is that's a planet I'm not familiar with. Because every primary care doctor, if I said to I've got about 150 primary care doctors that work in my department. If I announce to them today that you're going to get data on all 1,800 of your patients digitally in real time constantly, I will have 150 resignations on my in my email inbox by this afternoon at 5. I mean, it's impossible. And so that is more than telemedicine, sort of telemedicine plus digital data collection and data flow and data, connecting back to the patient is going to be the real game changer. And that's the part that we're going to spend the next 5 years trying to figure out how to make that work. So to me, it's very exciting because in many ways it should democratize care. It should allow patients to get more care at home without having to come in and see us. As AI gets better, more of the care will come from digital data that is collected, and then it's the AI thing that says to the patient, you need to increase your insulin or decrease your sugar or your salt or whatever. There's more opportunity to sort of automate some of it, but it's not going to be automated the way the rest of our lives are automated. There still are going to need to be people in the loop and trying to sort that out of who those people are, how do they get the information, how do they not get overwhelmed, how do you make sure they can still do their job, how do you make sure that patients are self-managing when that's appropriate, but don't do it when it's inappropriate? How do you create a world where patients do get information that says, you can raise your blood pressure medicine because the algorithm says so and it's safe to do that, but we don't say that the algorithm is the thing that tells you have cancer. Those are just incredibly hard questions in every possible way, ethically, practically, financially, how do we work that out? So that's why this is just going to be infinitely interesting over the next 10 years. And I think the last 5 years has just been the starting point to what I think ultimately is going to be a really good thing. It's going to be good for patients, good for healthcare organizations, but create a lot of disruption. So with that, I know I've gone on for a while, but let me stop and at least make sure we have 25 minutes or so for discussion.
Well, thank you for that. One thing that occurs to me is you kind of alluded to this, that the patient may get all this digital information, but they still have to mind their sugar intake or quit smoking or whatever have you. And it seems to be on top of that, they're going to need to manage their own digital information as well. Do you trust a patient to be able to do that?
Imperfectly, but first of all, it's not obvious to me that we have figured this out, that the physician telling the patient you should lose weight or you should stop smoking has worked all that marvelously well. Sometimes it does, sometimes it doesn't. And I think it's quite conceivable that we will come up with, when you think about how good Silicon Valley is at kind of knowing who we are and presenting to us an ad that we didn't even know we wanted to see because it looked like, we searched for something. And I mean, all that creepy stuff. At least theoretically, you can imagine a world where some combination of advice or prevention or interpretation that comes to the patient, sometimes from a person, but sometimes from a digital device that kind of knows you and knows how you learn best and what seems to motivate behavioral change better, could turn out to be more effective than what we currently do. Certainly its ability to give you advice in real time as you're about to do something wrong is a hell of a lot better than if we depend on, the advice coming when you see me every 3 months in clinic. So there's no good reason why it couldn't work well and work better and be more customized and personalized, but it's not, you don't snap your fingers and make it so. It's a lot of hard work and hard research. That's not just IT research and not clinical medicine research. It's psychology research, sociology, thinking about issues of disparities. Different people learn differently and have different forces that are at play in their life that we have to pay a lot of attention to. So I think it could work well, but we got a whole lot of work to do to make it work well.
Okay. All right. I've got a question from the audience here. It sounds like from your analysis, we are about halfway through the first phase of technological change. Other than telemedicine, what changes are you seeing in the way doctors are working?
Yeah, I wish we were well, first of all, halfway implies there's an end, and I think there will never be an end. I think this is sort of an ongoing process of refinement and iteration. But I think it's fair to say that if you believe in the productivity paradox idea that, that we're 10 years into the widespread digitization of medicine, and that we probably have another 10 years before we take full advantage of it, so that it meaningfully improves quality and the experience of patients and outcomes, and very importantly, lowers costs. So I think that's fair. In terms of sort of what it means today, I'll go on the wards in a week, and all of the data are digital. That's how I will record them. That's how I will see them. My orders will be digital, meaning if I'm prescribing a medicine for a patient and I am about to prescribe something they're allergic to or something that conflicts with another medicine they're on, the computer will signal me and prevent me from making kind of a dumb mistake like that. When the patient goes to a CVS or Walgreens, the prescription will go electronically to there. It won't be that I've got to give them a piece of paper that they carry with them. And there are some safety checks that are built into what Walgreens and CVS and others do. So that's all very healthy. There is a limited amount of decision support, meaning that I have a sort of given patient and I'm about to order a medicine or an X-ray, and the computer knows that that's not right for this particular patient, or it's risky in that particular patient, I may get an alert. Now, there's a problem there that we've not yet figured out, which is the problem of alert fatigue, meaning that when computers were just being put in place, everybody said one of the great things that they'll be able to do is alert the doctor when he or she's about to do something wrong. The problem is medicine is so complicated that if every time I was doing something that seemed a little dicey, two medicines that might have an interaction, or that leads to hundreds and hundreds of alerts a day. And because I am a human, my instinctive response to, and most of them are wrong or false alarms, my instinctive response to that is just to completely zone them out and pay no attention, just the way, when you're downloading a piece of software, you don't read the notice at all, you assume it's fine and click I accept. So,
you mentioned that with the 16-year-olds.
Yes, exactly. So the case I describe in the book is, has multiple, the reason I use it as the kind of fulcrum of the book was it just felt like it had everything embedded in it. It had alert fatigue. It had, people not talking to each other in a way that they used to talk to each other. It had sort of an initial pretty innocent glitch lead to all these downstream effects, and people just trusting the computer must be right. It's smarter than I am, and leading to, in the end, an act that could not have happened in paper world. A nurse could not have given a patient a 40-fold overdose of a medication, because the nurse would have had her brain working. She would have said, this is an absurd dose. That the medication that nurse gave that kid would be the equivalent of you driving down a highway and seeing a sign that said speed limit 2,500 miles per hour. It's completely absurd. And in the computer world, it's absurd, but we've all turned our brains off a little bit because you just learn to rely on the computer. As I've told people before, if I lost my phone, I might never see my wife again because I really can't remember her phone number, because I have only so many neurons still working, and I just choose not to waste neurons on remembering her phone number because it's in my phone. And it's just a perfectly human thing to do. So, the computer has made life a little bit easier for physicians, but also the promise of what we hoped it would be, which is it's giving us all this wonderful support and mining the literature, telling us for this particular patient, the best treatment or the best test is this one, not that one. That still happens in a very, very limited way, and it's going to be a while before we kind of completely figure that out.
Do you think that 16-year-old is any safer since you've written that book?
I think so. Because I think my book was the first one to come out as a cautionary note about digital. And one of the reasons I wrote it, and one of the reasons I was so proud of my organization for letting me tell that story, because obviously it's embarrassing at one level. And another level, I ultimately asked the CEO for permission, and he said, I think this is the kind of thing that's happening everywhere. And if we don't talk about it, everybody's going to keep on doing the same mistake. And when I published that, I had many, many people come up to me saying, we've seen the same thing. We thought, this is true of medical errors in general. We thought we were just uniquely stupid and uniquely careless and uniquely bad, as opposed to this is a systemic, problem and embedded in the way the computers are set up and the way humans interact with them. And so some of the root causes of that particular error have now been eradicated at our place and at other places. So now it would be impossible to give a stat charge without the computer signaling you and basically preventing you from doing it. And I think people are more attentive to issues around alert fatigue and some of the things that surprised me and surprised us at the time. I think people are more attuned to the idea that the computers, I don't think there's any question that they in aggregate make patients safer. But if you're not careful, they can also create new safety hazards that I think until I wrote that, most people had not paid a lot of attention to.
Okay. I've got another question from the audience. How do physicians examine certain body systems, such as listening to lung sounds or palpating an abdomen when they're using telemedicine?
Yeah, it's a great question. It's the answer sort of has two aspects to it, and one is really practical and important, and the other is not, but turns out to be important financially. So up till now, the way we document actually influences the amount we're paid for a given visit, and that includes the amount of physical exam that we do. It's kind of silly, but that's the way it is. So I see this, that people are documenting that they performed an abdominal exam, and the way they do it is they'll ask the patient to push down on his or her belly and then ask them whether it hurt, and they'll call that an abdominal exam. Whether it's legit or not, or whether they're just doing it to make sure that they can record that and then write for a bigger bill is a little bit up in the air. There are tools that can be used, but are not in wide use to listen to lungs, for example. There's a kit that some healthcare organizations are sending to patients for televisits that the patient can then put on their back, and then the lung sounds or the heart sounds are transmitted through digital the way, all sorts of other things are transmitted through digital. So it can be done. And for a patient in whom the lung sounds are particularly important, for example, a patient who might have pneumonia or a patient who has asthma or emphysema, I think it's reasonable to try to outfit the patients with those sort of tools. But I'd say in most cases, we fudge it. In most cases, if the patient has a lung problem and you're doing a televisit and you can't be confident in that what's going on in the lungs, you might be more likely to say the patient needs to get an oxygen saturation measured and probably to get a chest x-ray. I think over time we'll come up with ways to do this. Point of fact is the test characteristics of the exam are not that great. And it may be just as likely that rather than trying to figure out how we do a better heart exam with a stethoscope digitally, that patients, particularly patients with chronic illnesses where this is an ongoing problem, have a tool that is essentially a miniature echocardiogram, and they place it on their chest and the AI kicks in and reads it, or the doctor reads it through digital transmission. All that still needs to be worked out.
Okay. I've got another question. In chapter 19, you mentioned how family members are an extra check. Do you think that has been impacted, especially with COVID-19 now that visitors are limited and not always able to monitor what's happening?
First of all, thank you for the question. Obviously, you read the book, and it just strikes me 5 years ago, I would have instinctively said, oh, I know what's in chapter 19, and now I really remember. So, yeah, I think that family members are and can be an extra check. And I know this because when my parents have been hospitalized, my mother had lung surgery and my father had cardiac surgery, and I was, pulled up a cot by the bedside to basically prevent errors. And the number of times I caught something was significant. So it's sad that that's true, and it shouldn't be true. And, when I get on an airplane, I know there's not a damn thing I can do, and it should be that a patient, a family member has similar confidence, but it's just not the case. And so because of that, yeah, I think it's yet another tragedy of COVID. If you have an environment where, a sick person is in a hospital or even a nursing home and their family members can't be by their bedside, I think you've taken away, obviously, an important piece of psychological support, but you have taken away another part of the safety check that often makes the difference. In the case of the 16-year-old, you may recall that his mother was a absolute bulldog and would typically have been by the kid's bedside and would have tackled the nurse before she gave the kid 40 pills. It was, there's no question. But by this unbelievably horrible coincidence, the kid's sibling had the same disease and was hospitalized that day in our hospital on a different floor. And mom was with the sibling rather than with her kid, which was the last straw that allowed the error to get through.
Mhm, mhm. Okay. From a patient care perspective, what technology, you mentioned telemedicine, but what technology has been most helpful in fighting the current pandemic?
Boy, telemedicine hasn't really done anything to fight the pandemic, but it's allowed us to provide decent care to people that need it in a setting where we couldn't and didn't want to see them in practice. So I do think that's probably the game changer here. If you think about, because fighting the pandemic has so much to do with communication and messaging, you could argue that social media has been the most important in fighting the pandemic and also the most important in screwing up our fight to the pandemic by, it provides equal access to good information and bad information. So, I've been tweeting about the pandemic since this started. When I started, I had 20,000 followers, and now I have 105,000 followers. And I don't think I've gotten any better, or more interesting. It's clear that people need to learn about this and have looked for trusted sources to do that. And I'm the same way. I wake up every morning and go on to Twitter and see what people who I respect are seeing and commenting on and reading. So I think it's been, a remarkable way of getting information around. And it's true in even, we think about research findings. The fast track that we have of a study kind of reaching the public and being critiqued on Twitter has actually been amazing. And Twitter has formed a kind of funny form of review that mostly is self-correcting. I think when a bad study goes out, it gets critiqued very quickly on Twitter. But of course, it also has provided an equal opportunity for misinformation to get out that constantly has to be fought. But when I see, as I look at our scientists and the work they're doing, and how it's been accelerated by digital, and I don't just mean sort of new digital gizmos, but how it's allowed for worldwide collaborations. It's just not a big deal anymore for your lab to be collaborating with a lab in Paris and a lab in Tel Aviv and a lab in China, and to do that, almost as seamlessly as if you were, if they were 10 miles away. So I think digital's facilitation of communication and information flow probably has been the most important advance in the pandemic, because the pandemic really, there's no one point of view and one sort of technology that we need. It needs a combination of, we need virologists, we need epidemiologists, we need sociologists, psychologists, historians, librarians. I mean, everybody has to come together, and digital has provided for ways of doing that in a way that we couldn't have done 15, 20 years ago. So that to me is very exciting.
Definitely. I've got a question here about overdoses. Other than reducing alerts or adding color to alerts, did anything change or improve to prevent overdoses from happening? Pharmacists are still having multiple interruptions through order review, which each interruption increased the risk of medical error by 13%.
Yeah. Yeah, when you look at the alerts now that are at least the ones in Epic, they have redesigned them. So, one of the things that I pointed out, and I showed screenshots of this in the book, which, by the way, I got calls from Epic lawyers because at least under our contract with Epic, I was not supposed to show a screenshot of their screen, even if in doing so, the goal was to improve patient safety and see a risky condition. So I thought that was quite a bad thing that luckily they don't has softened some. But they're one of the things that Epic and other the EHR manufacturers have done is improve their alerts so that now it looks pretty different. It's less text heavy. It's more vivid. There's better visualization. It's and the alert for don't take that pill with grapefruit juice, and the alert for that's a 39-fold overdose look very different. I think that's been an important advance. At our place, it's not true everywhere, but at our place, there are now hard stops. One of the points that that 39-fold overdose happened in part because we had made the choice based on EPIC recommendations that there'd be no hard stops. There's no impossible prescription. And the reason was, in an academic health center, you're constantly using, research drugs and strange combinations. And if you create a hard stop where you've got to call someone to unlock it, it's like your password freezing, it's going to make people unhappy. But, we learned that it's better to make some people unhappy than not. It has to be that the computer system does not allow you to do something that is obviously crazy. And so you can't give a 39-fold dose place anymore without it being blocked.
Okay. I wanted to ask a question about personalized medicine because, well, for one thing, the program that's sponsoring this is very much involved in precision medicine. You write that in the world that you envision, the promise of personalized medicine will become a reality. Personalized medicine, precision medicine, is an important topic for many in medicine, including us at NNLM. Can you say more about how more personalized medicine will come about? Do you see it coming about as a result of the technology, or is it more driven by other factors?
I think the technology creates a scaffolding on which it can come about, but I don't think it really has in a meaningful way. I mean, my colleagues in oncology, it's real. I think, they see a patient who in the old days, they would say, this is stage 4 lung cancer and I treat it this way. But today they would say this is stage 4 lung cancer with this set of genetic markers or other genotypical or phenotypical differences. And I know that for those patients, they do better on drug X than drug Y. So oncology is sort of the case, at least in adult medicine, that proves that it's possible and it's going to become real for the rest of us. But for now, as I say, I'm going to go on clinical service in a few days, and in 10 days on service, the number of times that kind of digitally enabled precision medicine will change what I do is I'll be able to count them on one hand, and I'll be taking care of 50 or 60 patients and make several thousand decisions, but it will be quite unusual that it's the right treatment for sepsis in general is this, but because of this particular patient, sorry, that's our clock chirping in the background. I'll be done in a second. It's because of this patient and his or her genes or some other marker that's precise. The right antibiotic is not that one, it's this one, or the right treatment for their blood pressure is this one, not that one. It still is quite unusual. When it happens, when the data are clear enough that that's true, it will be massively dependent on digital. And the reason for that is partly the limitation of the human brain. I mean, if I'm in the outpatient practice and I'm seeing a patient with a high cholesterol or a high sugar or a high blood pressure, as a human with a regular old brain, I can remember that for high blood pressure, my best treatment is this. And maybe I can remember 1 or 2 permutations on that algorithm. If the patient also has diabetes, my best treatment is that. Or if the patient is over 60, my best treatment is that. That I can remember. If you start getting into, this is a patient with high blood pressure who on gene 22 has mutation 27.3.9, I'm dead. There's no possible way I can remember that. And so it has to be that decision support is embedded in a computer system that knows the gene marker and says to me, for this patient, doctor, just so you remember, the right treatment is this, not the standard treatment. Click here to order it. That is a fantasy right now. It doesn't yet exist, in part because we don't have full enough knowledge of the true precision treatments. But when we get them, then we're going to face this other almost equally daunting problem, which is how do you then embed it in the electronic health record in a way that is not overwhelming, is practical, has good visualizations, allow people to do what they to practice in a way that is feasible. That's a tricky problem.
Well, I want to thank you, Dr. Wachter, for taking the time to talk with us today. You've been really a wonderful speaker, and this is the launch of our series, so we really appreciate it.
Great. Thanks for having me. Really enjoyed it.
Okay. All right. The NNLM Reading Club's topic for July is Racism in Health, with a special focus on Black maternal health. Selections for the month are We Live for the We, The Political Power of Black Motherhood by Danny McClain, Battling Over Birth, Black Women and the Maternal Health Care Crisis, published by Black Women Birthing Justice, and Motherhood So White, a memoir of race, gender, and parenting in America by Nefertiti Austin. To learn more, visit nnlm.gov/allofus/NNLM Reading Club. And don't forget the hyphens. Once again, thank you to Dr. Wachter for speaking with us today and to the All of Us Research Program for its support of the NNLM Reading Club Presents series. Thank you to NNLM staff members Maddie Romancic, Michelle Spotts, and Darlene Caskey for planning and supporting this event today. To receive continuing education credit for this webinar, complete the class evaluation at nnlm.gov/Z, lowercase n, lowercase o. Once you complete the survey, you will receive a code that you can then use to claim your credit. Thanks for being with us, and thank you again to Dr. Wachter, and have a wonderful day, everybody. Dr. Wachter, are you there?
George.
Okay, great.
I'm
All right.
posting the links to the MLA CE survey. For some reason, they are not hyperlinking every time I post them, so I'm just doing it a couple times here.
Thank you very much. Thank you, everybody.
Yeah, thank you, everyone.
Thank you.
Take care.